Okay, you guys, so sorry for the delay. On behalf of Captain Goldstein, welcome to the Pikesville Volunteer Training Center. We super appreciate you being here. My name is Sean Barinholtz. I'm an anesthesia and ICU doc at Hopkins. I also have the honor of serving in the medical director's offices, car 609. Certainly on behalf of Jeff Sable, Director Shannon, Captain Willets, and the EMS office, I thank you guys for coming. We thank you for what you do. And the goal of this is to feed your dedication to lifelong learning. We're still working on live casting. There's a technical glitch, not surprisingly. So we'll continue to work on that, but we want to get started. So tonight, super thankful, Dr. Bontempo is an assistant professor in the Department of Emergency Medicine, University of Maryland. Dr. Bontempo completed her medical degree in Northwestern University, an emergency medicine residency at Northwestern Memorial Hospital. She spent 5 years at Harvard as an associate emergency medical program director, and then was recruited to Yale to become the EM program director. A position she's had for 7 years. She completed her master's degree in education. She's received numerous teaching awards in emergency medicine from Harvard, Yale, Northwestern Universities, and the University of Maryland. Bear with me. Dr. Bontempo has published in multiple emergency medicine textbooks and journals and has lectured nationally in the areas of cardiology and otolaryngology. And thank you for your generosity of being here and sharing.
You're welcome. You're welcome. Is that audio okay? Is that even on? I'm not sure that's on. Oh, test. Can you hear me anyway? Yeah, you're good? Okay. So that's a lot of introduction. I'm just Laura from University of Maryland. That's just who I am. That's my background and how I got here. And I'm really thankful that you guys invited me to come here. I think EMS is so cool. And I was a whiff away from doing an EMS fellowship when I got out of residency, but it turned out that I was graduating residency just when EMS went in front of the ACGME, which is the National Accrediting Board, to become official fellowship, and they got turned down right as I was graduating. So I was told, don't do it, it's a dead end, nothing's ever gonna happen, and now it's official. So, you know, my life took a different direction, which is fine, but I've always had a very soft spot for EMS, and I'm really excited that you guys invited me out, so thank you. We're gonna talk about tracheostomy emergencies. I have a advance here, and really how to save a life, right? Because tracheostomy emergencies, when trachs go bad, they go really bad. And of course, we're going to focus on the pre-hospital setting. It's what you guys do. You guys don't have all the resources around you that I do in the emergency department, so we'll really focus on what you can do when you pull up and you come on a disaster. So first of all, just a little bit of background. In the United States, we put in about 100,000 tracheostomies per year, and most people do very well, right? About 40 to 50% will actually have a complication of some sort, but those are mostly minor. About 1%, or about 1,000 patients a year, have catastrophic tracheostomy emergencies. And of those 1,000 people, half of those individuals will die from their tracheostomy emergency. So when you pull up on scene for a tracheostomy emergency, you're going to hope you're in that 99% and not in that 1%, but you guys all know it's going to be you that gets called for that 1% emergency, because that's just what happens, right? It's your shift, your time, you're the one who gets there. You have to be prepared to know what to do, all right? All right. Little background. Why do people have trachs in the first place, right? Why would we put a hole in someone's neck to allow them to breathe? Why would we do this to someone? Well, we do this to someone because of some sort of big categories. One is that they can't breathe through their mouth. There's some physical obstruction that's preventing them from breathing through their mouth or their nose. Most commonly, tumors, sometimes they're anatomic abnormalities, trauma, broken jaws, massive facial trauma, things along those lines. Control of secretions. If someone has copious secretions, for whatever reason they don't have a good swallow mechanism and they're aspirating those secretions, sometimes a tracheostomy is put in just to be able to control that so the patient doesn't continually aspirate. Long-term area management, right? This is your classic really bad COPD area. You've been smoking since they were 2. You know, they need a vent at night. They need to be vented, so they have their tracheostomy for venting. Or if you have a patient who has a traumatic brain injury and needs long-term vent management. That could also go along with control of secretions and things like that. And last big category are the kids, right? Tracheomalacia, the trachea rings don't really form very well. The trachea doesn't have a good structure to it, and the kids need trachs to come in, at least until they get bigger and the trachea kind of opens up, can get more definitive surgery, so those are usually temporary. So that's why we drill a hole in someone's neck, to allow them to breathe. Right. Where do we do this, and what's normal, right? To deal with abnormal, you have to know where you start with normal. So tracheostomies generally go in between the second and third tracheal rings. If you point on your own neck, it's not up here, right? Because this is where your larynx is. It's actually down about this area, usually right in the midline. Okay, and we put them in, and if you can see, I think there's a pointer on here. There we go, pointer. The trach comes in, right? It's a connection between the skin and the trachea where you're going to breathe. And trachs can either be uncuffed and fenestrated, means it has a hole in it to allow air to come in and out the end and air to come in and out the side. Or, there we go, they can be cuffed. So same trach, same location, but there's a balloon in there just like on an endotracheal tube, okay? What's the difference? If you try and vent through this, put the patient on positive pressure ventilation, air is going to go in, it's going to come out over here and head up, it's going to come out down here and head up. You put air in here, positive pressure, it's going down, it can't come back up, only one way in. So in order to vent a patient, you have to have a balloon on the trachea, which will be relevant when we talk about some of these emergencies. All right. Laryngectomy. Different animal. Really, really important that you can identify the difference between a laryngectomy and a tracheostomy. Laryngectomy, larynx is gone. There's no reversing this. The trachea is actually taken and put end on up to the skin. So if you look here, normal connection, right? You know, you breathe through your nose, you breathe through your mouth, you come down here, you have your esophagus in the back, and your air exchange goes here. Once you've had a laryngectomy, that's gone, okay? This is closed off. There's, you know, you can still swallow your food, but your trachea comes straight out, right? I know that I intubate in a wonderful emergency department with a patient on a bed and suction and the height is just right, and I know you guys intubate people practically upside down and all sorts of funky, weird situations out there when you're in the field. I don't care how mad your intubation skills are, you can't intubate a patient with a total laryngectomy. It can't be done. There is no connection between the two, okay? So if you try and you're hitting resistance and hitting resistance, you're hitting a dead end. It's not going to happen. As skilled as you may be, that's not possible, all right? So look back here. This brings me back. There's still a connection, right? When you come forward by one with a laryngectomy, there's no connection. It's a blind end. So side by side, tracheostomy. Detour, the road splits. You can have air coming into the mouth, you can have air coming into the neck. Laryngectomy, nothing. Road closed, there's no connection between the trachea and the mouth. All right? And you can see these tend to be larger, and they often don't have anything in them. The difference is really important for everything else we're going to talk about. So we're going to talk about what's in the hole, and then we're going to talk about how you play a little game, have you tell me if it's a tracheostomy or a laryngectomy. So what's in a tracheostomy? Generally a trach, right? Generally tracheal tubes. In a tracheostomy, it's these structured things. I'm sure you've all seen them. This purple thing is a speaking valve. Allows people to speak with their tracheostomy. The laryngectomies often have nothing in them at all. They can just be open. But you can have these things called Lary tubes. It just adds a little structure. They're not necessary. And you'll often see these. They're like flat button things. It just adds humidity. When we breathe, we get humidity from our mouth, right? Our mouth has saliva. We pull humidity from the air. From our mouth, we keep our lungs moist. Laryngectomy, no mouth, right? So these actually kind of in a cool way pull moisture from the air to keep the lungs have some element of moisture in them. Clearly not as much through your mouth. All right, game time. Laryngectomy versus tracheostomy. What do you think? Laryngectomy, right. Bigger hole, nothing in it. That's a gimme, right? Tracheostomy, you got that. It's got a trach in it. That's kind of easy. All right, now we can look at some pictures of some cute kids. What's that? It's a trach, right? So one of the other ways to tell a trach is that there's usually something that goes around the neck to hold the trach in place. You can see the trach collar there. Laryngectomy, if what's covering it falls out, I don't care. It's fine. You put it back in. It's no big deal. The trach, you really don't want that to fall out. And kids almost always have tracheostomies. Right? Adults get laryngectomies because of throat cancer, and you get throat cancer because you smoke. Kids don't smoke. Kids don't get throat cancer. It would be really rare to come upon a kid with a laryngectomy. It's almost always a tracheostomy. Okay? More cute babies. What's that? Trach, right? Tracheostomy. Mumble, mumble, what? What do you think, trach or laryngectomy? Laryngectomy, right? And that's one of those humidity valves in there. That's it. So it looks like a sort of a neutral tone, like Band-Aid, essentially. It looks like it's offering, all right? Cute kid with a collar, right? Around there, smiling happy. Definitely a trach. This one, maybe a little trickier. Save the hardest one for last. Yeah, it's actually a laryngectomy, you're right. And you can see, this actually is unusual that they have the collar, something going around the neck. But if you look, the hole is actually here, and it's much larger than the thing that's in it. So wider holes, nothing usually structured that goes into the hole itself, laryngectomy. And the difference between those two is really tremendous, and we'll talk more about that kind of as we get into the emergencies. All right, so what could go wrong? What could possibly go wrong when you get a hole in your neck and you're breathing through your neck? What could go wrong? Well, generally we group this into 3 categories. The intraoperative stuff, which is of no concern to you, and then the immediate post-operative period stuff like the first few weeks, and then the delayed stuff. The intraoperative stuff, you guys aren't in the OR. I know it doesn't involve you, but just for entertainment purposes, I want you to look at the 5th most common threat to your well-being in the operating room, getting a tracheostomy. Yeah, intraoperative fire, right? So the 5th greatest threat to your well-being is that your surgeon's gonna set you on fire during the operation. And I thought that was completely made up, because could you picture that surgical consent form? Infection, bleeding, I set you on fire, that kind of thing, right? But apparently it's because the patient's on oxygen and they're bovying down to the skin. So they actually have electrical cautery right by a high oxygen environment, and intraoperative fire actually is a real event that happens with tracheostomies. So, all right, besides for entertainment purposes, you're not worried about that, but I still think it's entertaining in 2018 that we have to have fire extinguishers in the operating room, but apparently they do. All right, we're gonna talk about the killers. The ones that you're going to worry about when you get that call of respiratory distress, and you may or may not know ahead of time the patient has a tracheostomy. 3 main categories, 3 things for you to worry about. They are decannulation, obstruction, and probably the most dreaded one, but thankfully the most uncommon, which is hemorrhage. Okay, decannulation is by far and away the most common emergency you're going to run into, then an obstruction, those are pretty close, and then hemorrhage. So let's start one at a time. All right, decannulation. What's decannulation? The damn thing falls out, right? It falls out. Someone pulls it out, it falls out, not being cared for properly. Patients with TBI, they may be moving, they may have a lot of secretion, so it's tough to keep anything, secure up in that area. It falls out. Why do we care? That's what's keeping their airway open, right? It's not a laryngectomy, it's a relatively small hole, and we have some trachs up here that you can take a look at. What's the first thing you do? Right, kind of EMS 1 or BLS 101, when you have someone who has respiratory distress, you put them on oxygen. Where are you going to put the oxygen on this patient? All right, on the hole? Sure, but put it on the mouth too, that's fine. Remember, there is a connection. So if there's a problem with the trach, problem with the hole, use your alternate route. Laryngectomy, what's this going to do? It's going to make the ambient oxygen a little higher, right? But it's not going to help the patient any. It's going to, maybe give them rosy red lips because their lips are really well oxygenated, but it's not getting to their lungs, right? So put the oxygen on, that's fine. Put a second oxygen on. Get a second setup, put it on their trach. If you don't have a fancy trach collar, I don't care. Put a second non-rebreather on there. Put a nasal cannula on there if you need to, but get a second oxygen source. Remember, there's an extra entry to the lungs with a tracheostomy patient. Use them both, not a problem. And if you mess up and the patient really had a laryngectomy and you put oxygen on their face, you haven't hurt them. You're not doing any harm to them. You're just wasting oxygen. We waste a lot worse than oxygen, so you're just wasting a little oxygen. But kind of finesse point to not put oxygen on the face of someone who's had a laryngectomy. So apply oxygen. That's the first step, basic things. And then the temptation may be to get the patient on the monitor, get them on the oxygen, and drive, which is reasonable given your transport time and if your patient is in distress or not. If you have a patient that has a trach that's greater than 7 days old, at just 7 days out from the trach being placed, that's considered a mature trach. And it seems really fast, but apparently it heals fast enough that the trach is actually adhered to the skin of the front of the neck. So be careful, but even if it's a week out, you can help that patient pre-hospital, help them in the field, help them in your rig. And what do? You gotta keep pointing this thing over here. So you suction, gentle suction, right? There might be some secretions that are built up there, gentle suction, not overly aggressive. I know you have the Yankauers, just suction right at the opening. That's totally fine. And then you can put it back in. If the tracheostomy tube fell out and it's there, you can put it back in. If it's dirty and fell into something horrible, you don't want to put it back in. If for some reason it's broken or can't be found, put an endotracheal tube in. The key with the endotracheal tube is when you intubate, right, you're used to putting it down to 21, 23 centimeters. You need to go 2-3 centimeters, right? Because you're already below the vocal cords, just enough to keep it secure. And then you have this big thing flopping out, just waiting to like fall out. Cut it. Just cut the tube, cut it and reconnect to your ambu bag if you need to, or oxygen source, whatever it is. Make it a whole lot shorter so it's not flopping around, because they're really hard to secure. You have to have one transporter, one medic hold that in place and hold the patient in place so they don't pull it back out, okay? You may say, but it's sterile, like the airway is sterile. How can I put a trach back in? If the trach is not grossly contaminated, if that's what you have, put it back in. If you have an endotracheal tube and you want to use that instead and you feel like you can secure it well enough, the patient's not thrashing around on you, then put that in. But if you have a TBI, combative patient who pulled it out, probably your best bet is to get that same trach back in that patient unless it is just grossly contaminated, okay? All right, and why? Why do we not say just drive and, you know, we'll get them in a controlled environment and we'll get deep suction and do that? Because these close. They actually close faster than you might think. Tracheostomies, even that have been in for a long time, within 12 hours, they'll reduce in diameter by about 50%. So 12 hours seems like a long time, but if someone went to bed the night before, fell out sometime during the night, so they're not vented at night, they wake up, they call you, someone tries to put it back in at home first probably, you all transport from nursing homes, so, shift change, notices, whatever it may be, it could be several hours that can already be smaller. So it's fine. Put it back in. Use some lube if you're having difficulty, downsize if you're having difficulty. If the patient's in any respiratory distress, get something in that hole, right? The hole is too small. This hole's going to keep getting smaller. You're not going to watch it close in front of your eyes, but the first 50%, it's going to narrow it down relatively quickly. Put something in there, especially if your patient is in respiratory distress. All right. What do you put in there, though, right? So it's a little bit of a numbers game. There are multiple brands, and the tracheostomies are measured by their internal diameter, same as endotracheal tubes are, right? It's the internal diameter that does it. If you look at an endotracheal tube, this is a 6.0. You can see internal diameter 6.0, outside diameter is 8.8. So a bit of a difference, up to 2-3 millimeter difference on an endotracheal tube. If you look, I don't know why we can't get this regulated, but different brand names, they all have numbers, but this number doesn't necessarily correlate to the size of the tracheostomy tube just to make your lives that much harder. That's the only reason they do this, to make you more confused. So very popular brand, Shiley, right? And number 8 Shiley has an internal diameter of approximately a 7.5 tube. It is close, right? I don't expect you to memorize this. I don't expect you to know the brand names. Bottom line is, grab an endotracheal tube that is the same size as the number here that fell out, if you know, and if it's having any resistance, just grab a smaller one. That's all. The other thing to notice is that this is about a 3 millimeter difference. Some of these, like a 7.6, has an outside diameter of 12.2. That's a pretty big difference when you're trying to feed something to someone's airway. So if you're hitting resistance, but it's the same, it should be the same size, it's the external diameter that's causing the trouble, just downsize, okay? All right. If you are the black cloud and you get a call for respiratory distress and a patient with a trach that's out, and you ask that first critical question, how long have you had your trach? And they say, we just got home from the hospital yesterday and we got it put in 4 days ago, you don't have a whole lot of options pre-hospital. If the patient is not in extremis, apply your oxygen. But if the patient is not in extremis, get it closer. This is a troubling situation. Yes?
Yeah,
Yeah, it can be. It can be. It depends what it was put in for. If it was TBI, they're usually in the hospital longer. But if it was a planned tracheostomy for a COPD patient that's just sort of needed more and more vents, and it's a planned thing, and they're going to be vented at home, that's all set up, they may be home in that time frame. Right? Don't forget get patients in and out of hospitals. That's the idea. So patients can get home within the week, and all they have to be home is post-op 5 days. Say they're there. They're home. Day 7, you get them. People are unfamiliar, it's all brand new, they don't know how to care for them particularly well, falls out, panic ensues. So it's trouble. The reason you can't insert something blindly, you can't just put that trach back in, you can't just put that endotracheal tube in, is that trachea is not yet fully secured to the skin. And the risk is you disrupt that very delicate connection and the trachea falls backwards, and you have a hole in the skin, and you have a hole somewhere in there, in the neck, and connecting them can be very difficult. It can be difficult in a thin patient. It can be impossible in a thin patient. It's always going to be difficult in a patient that has any excess body mass around their neck. It's going to be really hard. So if the patient is not an extremis, or if the patient is looking borderline extremis and you can keep their sats up on oxygen, just drive really fast, right? And you'll get them and you call ahead and let us know, and we'll get an OR ready, and we'll get a fiber optic scope. We're not going to touch this in the ED unless it's an extreme situation. You just run the risk of having the trachea fall back into the neck, and you can't get to it. Okay. So we would do things like a fiber optic scope, a bougie, which is stiff, so if I can pass it once and get it in, even if the trachea falls back, I've created a bridge. I can put my endotracheal tube over that. Less than 7 days, it gets pretty dicey when these things fall out. And it's kind of a bad situation because that's when the family's least used to dealing with it, and it's sort of a high-risk time. So don't mess with it if you don't have to. If you have to, see if you can get something stiff in there in the first pass, like a bougie, something where you can bridge in between, or go with a really small endotracheal tube, just one enough to keep the patient alive, to bridge, and we can always change it up to something bigger over a fiber optic scope when you get to the hospital. And preferably in the OR, do all that in the OR. All right. Any questions so far about decannulation? Who's had a call that involves this? You're kidding. Not yet? Tomorrow. Someone's getting the call tomorrow. You've had one. Yeah, what happened? You put an endotracheal tube in? Was it hard to keep it secured? You cut it and you held it? You just held it for the patient, or was the patient cooperative? Patient was cooperative? Yeah, all right, that's good. All right, you got to cut it, because otherwise you have that big long thing, 15 centimeters flopping around. It's just bound to fall out. All right. That's decannulation. You're going to get those a lot. I know that I see them a lot in the emergency department. We have, we're part of shock trauma. We have a huge ENT service by us, so we see a lot of patients with trachs, and they fall out. And some people are very comfortable putting them back in, and some families get nervous, and I can't blame them for getting nervous, especially the kids. They fall out. We had a pediatric arrest a couple months ago at this point because it was a relatively new trach. Trach fell out at home. The kid was vent dependent with the trach. Family didn't know what to do, and I can't blame the family for that. They weren't medical people. They called. I don't think they called the EMS. I think they threw the kid in the car and drove really fast and got to us. The kid actually arrested by the time they got in, and it was for us, a relatively simple manner of getting a new trach in and getting the kid vented. The kid did survive because it was soon enough, but I think there was a anoxic brain injury. So that's something that is risky, and it's sad. That's why I want you guys to know how to deal with this stuff. All right. Next, obstruction. So if it doesn't fall out, it can get blocked, right? And if it gets blocked, it's a blocked airway. That's what it is. It's like your patient's choking, except they're choking through their trach, as opposed to choking through their mouth. All right. First step, same. Right? Patients in respiratory distress, you're going to put them on the oxygen, 2 setups, get them on oxygen both ways. Now, what blocks the tracheostomies? Gunk and yuck blocks tracheostomies. Anything you can think of blocks the tracheostomies, right? It's either an acute mucus plug like this here that just got in there and blocked it acutely, or it's this gradual buildup of secretions for people who aren't cleaning their tracheostomies. This is actually this tube cut in half. That's cut in half. That's what it looks like on the inside. That's called a tracheostomy cast, because it essentially forms a cast on the inside. We have a lot of patients that don't take particularly good care of their trachs. They just don't. And they come in, and we definitely have patients who come in and they are in extremis, and all we do is relieve the obstruction, and they feel great, and they go home, right? They come in like hypoxic and uncomfortable, choking. You can fix it. You can make your patient feel better, and this is certainly something you should do pre-hospital. No question about it. All right, so the other thing to know, besides secretions building up, is that a trach can actually block itself. Right? If you look at this CAT scan, this is a tracheostomy, and if you look, it's not fenestrated, right? It's solid on both sides, and the opening is up against the back of the trachea wall. So the trachea is blocking the tracheostomy. How do you think you fix this? You wiggle it, advance it, pull it out, just move it a little bit one way or the other. All right, there's some play here. If you move a tracheostomy out 5 millimeters or push it in 5 millimeters, you're not going to hurt anything. So feel free to do that. All right, so what do? You get there, your patient's like leaning forward, they're uncomfortable, you can hear it, right? It sounds like stridor because the thing is partially blocked. That makes sense. Stepwise approach. First of all, take anything off that's on the outside of it, right? So do the simple things first. Most commonly, that's going to be a speaking valve. Okay? Most commonly, you're going to see one of these purple things in there. Maybe it got some secretions in it, something. Take that off. That's the obvious stuff. What I have found out by looking at what else can block a tracheostomy tube is that there's a whole world of fashion out there that you might not have known about, right? These are tracheostomy scarves to cover the tracheostomy, and this, I think, is the most clever thing of all. This is tracheostomy jewelry. It has a hole in the center of it so you can breathe, right? But it kind of looks decorative. So if you're not looking too closely at someone, you might not notice they have a tracheostomy. And that's kind of good for the patient who's out, out and about living their life, doing things. No one has to be staring at their neck. But just take all that stuff off. Anything that's blocking the end is going to make the patient not breathe well. Okay, so and if you hear stridor and your patient's wearing one of these lovely things, peek underneath. You might find a tracheostomy that you weren't expecting. All right, so take all that stuff off. Yes? Do you have a question? Oh, sorry, just that's right. Yes? That just pops off. It's not even a screw, you just pull it. Yep, just pops right off. Easy. Okay. The next question is, you have a single cannula or a double cannula. Kids generally have these because their necks are smaller. They can't spare the extra space. Adults almost always have a double cannula. It'd be really rare, thankfully, for an adult to have a single cannula. And it's really rare for a small child to have a double cannula, just because it adds millimeters to the device. Yeah. So it's great when it looks like that, and you can see single versus double, but you're not seeing that. You're seeing it when it's still in the neck. So what do they look like from the outside? This is what it looks like from the outside. This is a single cannula. You can see it's one solid piece. It has the pilot balloon tubing here, one solid piece. This is the double cannula, and it has these butterfly wings. This is all solid, and this actually pops out. And we have some trachs here, and I want you guys to just practice taking this out. It takes a little bit, not a lot, but a little bit of a pull. You can't be too gentle with it. You just got to give it a squeeze, and then pull it out. All right. So you should practice doing that because this maneuver is going to relieve most of your obstructions. Because this stays clean. This is what gets blocked. You take it out. If you have another one, get rid of this. If you don't have another one, just clean it. Just clean it with soap and water, run it underwater. A lot of times this stuff is so gunked up, it's hard to get stuff out of it, but this can absolutely go back in, okay? So why don't you take a feel of that one. And I'll have another one up here, I believe. This is a locking one. This one doesn't have the butterfly wings, but it turns, and then you pull it out. You just have to remember that you pull along the curve rather than you're kind of fighting with it. And that right there can save a life, or save an anoxic brain injury, as happened to the kid who came in. So that's what they look like from the outside. These are two good examples. Yeah?
Is there, if you pull that out and you solve the breathing problem and you put it back in, is there any reason you need to put it back in?
You need that to hook it up to an ambu bag. The outer cannula won't hook up to an ambu bag. So if you need to vent the patient, then you actually need to put a new inner cannula in.
But if you didn't need the bag or anything, they could.
Oh, absolutely. That's the beauty of it. Take it out. Absolutely, yes.
If you have a single cannula on a pediatric patient that's greater than a week old and you just can't clear the blockage, should you just take the trach out?
You're my lead man. I'm going to get to that right now, as a matter of fact. It's great. No, I love it. So what do? First thing you do, you take everything off the outside, decide if you have a single cannula or a double cannula. Double cannula is kind of easy, right? Just take out the inner cannula. 90% of the time, that's all you have to do. I've had patients that, I mean, literally have come into intake, like leaning forward, hypoxic, really in distress. We take out the inner cannula, and they pretty much go, thank you, that's much better. And you look like a hero because you took out the inner cannula. That's all it is. If that doesn't work, or if you have a single cannula, you have to try and suction, right? Suction. Sometimes even a hemostat, just pulling the junk out from the inside. I had a resident, the guy came in, he was in extremis, the whole thing was caked over. I don't think he'd care for this thing at all. We couldn't get the inner cannula out because it was so caked with secretions, it was literally stuck. So she took 2 hemostats and just started pulling the thing out, and it was like a sleeve, a scarf coming out of a magician's sleeve. It was unbelievable how much came out. I thought we were in the right main stem. I did, and then we pulled the whole thing out, and he was better. So if you have a single cannula, if you can't suction, you can actually mechanically try and remove an obstruction that way too. Suction with the Yankauer that you guys have, it's going to be limited, right? We have those flexible suction catheters that can kind of snake their way down. Those are great. You don't have them, suction what you can, do the best that you can there. If that fixes it, great. You're a hero, patient feels better. If you need to ventilate them, you need to put a new inner cannula in. Put them on capnometry. If you need to just see if they're breathing, do what you would normally do to monitor your respiratory distress patient. Okay? Just remember, you can't hook up to an ambu bag without a new inner cannula in. And those inner cannulas, they can be washed. Like if you just want to give it a quick, like in the sink, put a cotton swab in there, clear whatever out there, and pop it back in. Go for it. Just, you're pre-hospital. You guys are like emergency medicine. Duct tape and a stethoscope and a hemostat. You can fix about anything. Just fix it, put it back in. All right. What if that doesn't work? So what if, your day's not going well, the patient's day isn't going well, you try that, doesn't work. Move it a little bit, right? Remember we talked about the trachea actually blocking the end of the tracheostomy? Move it in a little bit, move it out a little bit, see what you get. And if that works, fantastic, problem solved. Ventilate if you need to, hook them up to an ambu bag, normal monitoring of your patient, normal monitoring of their ventilation. All right, and that's what we're talking about there. If that doesn't work, this is where things get dicey. You have a patient in respiratory distress. They have a balloon, if it's a cuffed trach, in their airway. Nothing's getting through the center of that trachea, and because the balloon's up, nothing's getting around the tracheostomy. So you have a blockage. So now you need to deflate the cuff. You deflate the cuff because here's normal ventilation with the tracheostomy. Air goes in just through the center. If that's blocked and you have that cuff up, nothing's getting in. If you do this, right, and now the cuff is down, well, what happens? That's blocked, but okay, your air goes around it. Right? So it seems maybe counterintuitive to take the balloon down in a patient who's in respiratory distress, but that's what you need to do. You have to give them an alternative route, a detour for the air to get around that blocked area. Put them on oxygen. Put them on oxygen by their mouth now, right? Because again, they're not getting anything through the tracheostomy tube. Always safe with a double setup. You can always put on a double setup and figure it out later once you've stabilized your patient. Normal monitoring of your patient. If you're having a really bad day and that doesn't work, right? Or if it wasn't cuffed in the first place, I'm going to ask you to do something that is completely, absolutely, utterly counterintuitive. You're going to take out the patient's airway. Why would you take out the airway in a patient in respiratory distress? Because the airway is the problem, right? It takes some steady nerves to pull out a tracheostomy in a patient who's not breathing well, but if the tracheostomy is the problem, the tracheostomy's got to go. So you need to take it out, you need to suction, you need to put them on oxygen. If that clears up, then just drive, you have time. Tracheostomies don't close that quickly, right? They close over hours, within minutes. Get them to the hospital. If your patient is in some distress or they have anoxic injury or they even have become apneic because their airway was blocked for so long, pop an endotracheal tube in, blow up that balloon and ventilate your patient. That make sense? Has anyone had to take out a tracheostomy tube that was in? No? Yes, you did. What happened? Oh, well, we're getting to that. Okay, we'll talk about that in a few minutes. You had high drama then. Okay, we're going to talk about your high drama in a little bit. So pretty much a stepwise approach, right? And knowing what to do, think I'm going to try and use the airway that I have. I'm going to try and clear the tracheostomy that's there. Okay, that's not working. I'm going to try and work around the tracheostomy tube. Okay, that's not working. I'm taking the tracheostomy tube out. That's sort of your big picture, 3 big steps. Okay? You guys have questions about those steps? Right? It's uncomfortable to take out a tracheostomy, take out a definitive airway, and someone who's having breathing problems, but that's just the thing to do if you get that far down the algorithm. All right. If all else fails, tracheostomy is out, can't, for some reason it's too small, you can't get a tube in, remember there is a connection. Now that connection, even though it's there, might have a tumor between you and the airway. It might have something else that's actually blocking your way of getting there. I know you guys are all good at intubations. You intubate in crazy circumstances, so you'd be ready to intubate this patient, but although this person looks nice and calm, I would think if I was in the situation, I'd look more like that. I think that's what it would be more of, because you know you're going to have a tough airway. That tracheostomy went in for a reason. It's going to be tough, right? But this is the last step in your algorithm. If your patient is dying because they don't have an airway, you tried everything to utilize a surgical airway, you got to go from above. You have to try and get a tube in. Put a small tube in. Just get something in that patient to keep them ventilated until they get to the hospital. Okay? Yes?
A patient that has a trach, do they still change them out of frequency, a certain frequency?
They should. They should absolutely. They should absolutely take care of the trach, and if nothing else, if they don't feel comfortable doing that, they should be changing or cleaning and replacing the inner cannula every day, right? And that's high maintenance. And if the person can't do it for themselves, then you're relying on a caregiver to do it. And the care the caregivers give is variable. We know that, right? That's the real world. People have jobs and other family members to care for, and nursing homes vary in quality, one might say. So yes, they should. In a perfect world, it'd be fine, but this definitely happens. I see patients with just these really nasty, junked up trachs. And honestly, we have homeless patients that have trachs, and they just don't have access to the water and soap and things like that on a regular basis to allow them to clean it, and it's pretty tough. Okay, so hopefully you do it like this and not like this, but you should appropriately be nervous if you're intubating a tracheostomy patient. Anything else about decannulations? No? All right, remember, save a life. Minutes between life and death for your patient, and also life and anoxic brain injury. So if your patient is in any sort of distress, you've got to have the algorithm in your head to know what you're doing. And I try and break it down so I don't, no one, you memorize. You guys have a gazillion things to memorize. You're never going to memorize it. So just think you're going to try and use the airway you have. If that doesn't work, the airway's gone. You've got to go on to your next step. Okay? All right. What? You intubate people that aren't breathing and what?
And do not have a bag reflex.
Yeah. Mm-hmm.
So these people are still breathing?
Maybe, yeah. If they're an extremis, you have to intubate them. Yeah, and they might throw up. It's possible, and that's the advantage that I have. Some have paralytics, yeah? You guys use paralytics? No? No one? County does not use paralytics? Okay. All right, city uses paralytics, I know that. So yeah, I have that advantage. There's no question I have a better deal than you do. I have a whole hospital, you have a rig, right? To intubate. Yeah, do the best that you can. I mean, you're only gonna do it if you've gone all the way down that algorithm, your patient's in extremis, and you're trying to save a life. That's what it comes down to. Okay, and just quick tip, remember, you can't intubate a total laryngectomy patient. I'm going to circle back to that, because if you get to that point and you're trying to get into the mouth, you're simply wasting time. You're making your patient more hypoxic. You're not helping the situation any. Okay. All right. So total laryngectomy patients cannot be intubated. In big red letters, you can't do it. Okay. All right. And the reason I put this up and circle back to it is studies that scare you to read. No offense, they asked a bunch of anesthesiologists about intubating laryngectomy patients, and something like 9% didn't know you couldn't intubate a total laryngectomy patient, and that's what they do for a living. So kind of scary, so I'm kind of going over it a few times with you guys, okay? All right, you can't do it. No offense to our anesthesiologists in the room. I'm sure that you were in the 91%, I have no doubt about that, but 9% did not know you couldn't intubate that, so, okay. All right. If you need to ventilate your patient, because that's the one thing we didn't talk about, right? You're trying to save this life, you're trying to clear that airway obstruction, you've got that trach out, and you're just trying, the patient's hypoxic, you're trying to bag them up before you got the definitive airway back in. How do you bag a patient with a tracheostomy but no tracheostomy tube in place? Well, one of two ways. You cover the ostomy and you bag them through the mouth, right? It's a two-person technique. You have to have someone covering this, because what happens if you blow the air in here? Right out the neck, right? In one hole and out the other. That's what's going to happen. You have to cover this with a pretty good seal. If you're not getting good air movement through the mouth, or if this looks like it's patent enough to move air, but you can't actually get a tube in there, or you just need to bag them up before you try, you have to do something that looks like you're trying to kill your patient. And that is, you have to bag down here, but you have to cover their nose and mouth. Okay, you have to look like you're suffocating your patient, because you need to block off the airflow through the nose and mouth. I don't suggest doing this at the roadside, because people might call the cops on you, right? But you have to cover it. You have to squeeze the nose, cover the mouth, get your neonatal mask, and put it right down there on the base and ventilate. The neonatal mask works remarkably well. It fits for most people, right? That's the size of the tracheostomies. So ventilate away, but remember, whichever one you choose, you've got to cover the other, or you're not going to get enough air down to the lungs. Okay? All right. All right. And finally, then we'll get you guys up and let you move around, get your hands on stuff, is we're going to talk about the least common, but oh my gosh, you'll remember it if it ever happens to you, is the hemorrhage from the tracheostomy tube. Okay, these are serious things. These are really no joke around things. Right, beware of all of it. If it's bleeding, beware of the tracheostomy. Right, beware of everything, because it can be minor if you're lucky. It can be major if you're unlucky, and it sounds like you were the unlucky one that had the major bleed. And we'll talk about that more in a moment. It's dramatic, you don't forget them. All right, so first thing, back to basics, right? Respiratory distress in a patient, put them on the oxygen. Put them on the two collars, double set up, have the oxygen flow, get your patient oxygenated. This is what you worry about. This is what kills patients with tracheostomies the fastest, okay? When someone has a tracheoinnominate artery fistula, they die almost all the time, unless someone gets them really fast and that someone knows what they're doing. Let's talk about what this is. This is your trachea, right? And that's your anatomy. That's big red aorta, and this is your right innominate artery that comes right off the aorta, right? Heart's down here, blood's coming up, your right innominate artery, left internal jugular, left subclavian. The balloon sits right about there, right? In a normal anatomy, everyone has variations, but in most folks, the balloon ends up a little higher and the artery's down a little lower. In some unlucky individuals, the balloon and the artery are right next to each other, right? And over time, with that balloon, if you press on something long enough, you're going to create a hole in it. It's just pressure necrosis. The balloons in tracheostomies have changed to try and minimize this risk, but it still is a risk, okay? The balloons have actually gotten longer, so the pressure is spaced out over more distance and not quite so focal as a sphere would do. But these are still the majority of what we see. And when that erodes through, you have your high pressure aorta dumping into your zero pressure trachea, and you bleed quickly. Okay. So why am I telling you this if I tell you that everybody dies? It's so depressing, right? Okay. This is massive. And when does it happen? It happens usually within the first 2 weeks or within the first 3 weeks, right? 80% of these are going to occur in the first 3 weeks. So certainly long enough for someone to get home and then come back. But these have been reported up to 6 years out. 6 years out. There's one they think happened actually 12 years out. They think that was the cause of the massive hemoptysis. Never got an autopsy, so don't know. Ooh, got quiet. But it can happen at any point. But most highest risk is in the first 3 weeks. All right. Yes. Greater than 90% of people die, 98% in some studies. They're all small case reports. So why am I telling you? Well, two reasons. One, 50% of these patients will have a sentinel bleed. They'll bleed a little bit before they bleed a lot, right? So any tracheal bleeding must be taken seriously. Don't get there and have the patient say, oh, it stopped. I'm good. I'll see my doctor tomorrow. You have to lean on those patients and tell them just how dangerous this is. That could be their warning shot, and if they don't pay attention to it, that it could kill them for the next 24 hours or 72 hours. Right. So that's the first part. And the other thing is that it's 90%. It's not 100%. And if you get there and you get to the patient fast enough, you might be able to save that patient's life. Total hero. You're going to get a plaque on the wall. You'll be in the newspaper, but you'll save the patient's life. Okay. This is the first really important part. You have to convince the patient that we really have to find out where this bleeding was from. Now, if there's a cut on the neck around the trach and you can see it, fine. But unless you can actually see that source with your eyes, you have to get that patient to a hospital, even if they look great, until they really need to come, because they really need to figure it out. And when you get to the hospital, we'll do the same thing. We'll look with our eyes, or we'll look with a scope, or you look with a CT scan or a CTA. So I know you don't have access to this pre-hospital, right? They don't have that in the back of your rig, but this is what you're looking for. I just thought you might like to see the anatomic picture. This is your aorta. That's your right innominate artery. Here are the other two great vessels coming off the other side. And this little thing, that's what kills you. That little connection right there. And you can see in the 3D reconstruction here. That tiny little thing is what dumps all of this out up that way, okay? And all over the place. All right. So what do you do if you come up and you see this? First of all, get your eyewear on. You're going to get splashed, right? This is an arterial bleed. So protect yourselves always. You know that, number one. I don't need to tell you that. Compress, right? When something bleeds, you compress. How do you compress this? Uncomfortable. You can try it on yourselves. Take your fingers just above the sternal notch and press posteriorly. It's not nice. It doesn't feel good, but you're pressing on your trachea, and hopefully you can press your trachea posteriorly and cause some compression on that innominate artery. Try and stem the bleed a little bit. Doesn't feel good. Doesn't feel good what I'm doing to myself, but if it saves a life, you can apologize later to your patient, which is fine. And then your basic stuff: resuscitate. Get 2 really big IVs in them. Get fluids going. Figure out where your closest facility is going to be. All that stuff that I know you guys well know how to do. Call ahead, let us know, because if you call ahead and you tell us you have a bleeding trachea, we're going to have a recess room open, we're going to have O-negative blood at the bedside, we're going to have ENT and IR and vascular, we're going to have a scalpel, we're going to have everything there. So give us as much warning as you can, because we're going to mobilize a lot of resources to try and save this patient's life. And then drive really fast. Drive really, really fast, because you have minutes to try and save this patient. Because whatever you're doing pre-hospital is going to be temporizing. But there is a really important thing that you can do pre-hospital that might get you out of this very dangerous situation. After you apply pressure, the balloon that caused the problem can now become your friend. The thing that was the enemy in the first place can now become your friend. You take that balloon that's causing the problem and you overinflate it. You use it as a tamponade device. How much air do you put in a tracheal balloon? 10 cc's, right? Okay, so here we go. Here's our trach. I'm gonna put my 10 cc's in, right? It's full, normal, and I can feel the pilot balloon, right? That's causing the problem. It's bleeding around this. I need another 10 cc's in there. So we're up to 20 now, right? You look at the size of that, and again, just slow, gradual. And it gets harder because the pressure in the balloon gets higher. So we're at 30, right? Take that, twist that off. 10 more. Give me one more.
Are you sure about this?
I'm sure, as long as you push it gradually with even pressure. I won't tell you how much it can hold, but you'll find out. You know what? If your patient is dying, you're going to do it, right? Okay? So see how much bigger that balloon is? That can tamponade. That can be the difference between life and death for your patient. And yeah, you can pass that around if you want. That's 40. They can hold up to 50 cc's. If I got to 40 and the bleeding was slowing down, I wouldn't push my luck, because if you pop the balloon, you're worse off than when you started, right? So 40 cc's. Again, as long as you're not slamming it in. It's actually pretty hard when you push that last one. I imagine you have to put some effort behind it, because the pressure gets pretty high in the balloon, but that's what you're going for. You want that balloon pressure to get high to see if you can tamponade, right? That may give you enough time to get the patient to an operating room, to an emergency department in an operating room. All right, so there you go. There's your pressure, you push there, and you overinflate the cuff. See, look what happens when you overinflate that cuff. You take this balloon, and it now presses out and out and out, and you're actually compressing against that artery, hopefully stemming the flow if that bleeds somewhat. All right?
So there was a question from
Yeah,
the
sure.
live stream. If you could just show that trach in the balloon
Sure.
in front of them.
Who's got the trach?
And demonstrate how to apply posterior pressure to sternal notch for those of us.
Okay, so there's a picture up here, and that's only one finger, but you're going to take your 2 fingers. You might even take some gauze to, where am I going? Over there. Ah, sorry. Oh, I didn't realize. I would have, hello. You're gonna take your fingers just above the sternal notch, maybe use some gauze to help spread out the pressure, and push posteriorly. It's uncomfortable. You'll know if you're in the right spot because you can actually hear my voice changing a little bit. I'm pushing on the trachea. And this is the balloon that we inflated. Has 40 cc's in it. There you can see it there, and it's pretty tight, right? Pretty hard to push it in. As long as you're pushing gradually, you can bring this up to 50 cc's. All right. And hopefully you get tamponade there. So if that doesn't work, you're getting into an even more serious situation. Now, before we talk about that, you said, what if the trach is uncuffed, right? What if I'm really unlucky and this person has a fistula that formed without a cuffed tube? Well, unlikely, right? That's an unlikely circumstance because it is usually the cuff that causes the problem. But the tip can cause the problem. It can happen. This is rough, okay? If it's more than 7 days old, you have a bleeding airway, a patient in extremis, you gotta summon up your courage and you gotta take that thing out. You gotta take it out. You're gonna remove the definitive airway on someone who has a bloody airway. That's a tough thing to convince yourself to do, but if you can't stop the bleeding, you've gotta get that uncuffed trach out and get something in there with a balloon, okay? I see people looking uncomfortable, and I understand why you look uncomfortable because it's an uncomfortable thing to do. But if that's what's going to save their life, you have to do it. You're not going to make your patient any worse, right? That's the bottom line there. So then put something in there. If you have a trach, and you have it right there, fine. If you just grab the nearest thing you can that has a cuff on it, you can overinflate the endotracheal tube cuff. You can put up to 50 cc's in an endotracheal tube cuff as well. And I don't know if we don't have one up here, but I know you guys have access to them in your training. Slowly inflate, feel how hard it is to push that in. The pilot balloon is useless at that point because you've already hit the maximum that the pilot balloon is going to tell you that you have in there, but overinflate, okay?
There's another question online that says, how hard do you push? Are you worried about asphyxiation when putting pressure on the trach?
You push hard enough to stop the bleeding and you follow the pulse ox. And if you have to let up intermittently, you let up and then you push again. Okay, so it's sort of like compressing an artery, and you don't want to let up, but you're compressing the airway as well. So follow the pulse ox, hold as long as you can, as hard as you can. You're not going to break the trachea. You're not going to do that. You have tracheal rings, so you have structure to it. Yeah?
They should be able to breathe through their cannula.
Should, but the probability of that is going to be blocked with blood. It's fresh blood, it's going to clot. It's pretty fast flow. So yeah, they should be able to do that too. Either way, you have to try and stop that bleed and monitor the respiratory status. If you have to let up, you let up. And if you can compress and then bag through the tracheostomy, perfect, right? You can push positive pressure in while you're trying to compress that artery. Every situation is going to be dynamic. There's no question about that. All right, so you get something in there and you overinflate the cuff. All right, so there you go. Put the endotracheal tube in, overinflate that cuff, see if you can stem the bleeding. Next, if that's not working, you can intubate from above, right? Get something in the airway to keep your patient oxygenated, as we talked about compressing the airway, and then take the trach out, right? We already talked about taking the trach out. If it's uncuffed, you have to take it out, you take it out. This is the real extreme, right? You do something to secure the airway, and then you hold pressure. This pressure is a little bit different. And you've all held pressure on wounds, and I guarantee that all of you, except maybe one, has never held pressure this way, is that you put your finger in there. You literally put your finger in the stoma and you pull forward because the artery's in front. So you can put a finger in there and you pull forward. What's the one problem with holding pressure like this? You're blocking the airway, right? Kind of tricky, right? So if you can get a tube in from above, go for it. That's great. If you can't, you compress until your patient's pulse ox is no longer tolerable to you. You let up, you let him breathe, you let him bleed, and then you compress again while you're driving very quickly to definitive care. Okay, all right. What happened with your bleed?
It was a fairly fresh trach. It occurred in the dialysis lab.
Oh.
While she was getting dialysis, so she was heparinized. She started oozing through it. They thought, oh, the heparin, and then it all let loose.
Mm-hmm.
Ended up in the dialysis lab. I intubated from above
Mm-hmm.
through it, pulled the trach out after I went through the cords,
Mm-hmm.
pushed it past the trach, inflated the cup, and somebody reached in and pushed it, took her to the OR.
Survived?
2 hours,
Mm-hmm.
no. We
Didn't
ended up
survive.
packing her chest. They couldn't get the bleeding under control.
Yeah.
And after a lot of blood, That included a thoracic surgery and a vascular surgery.
Yeah, these are really tough things, and it sounds like all the right stuff was done. Yeah, that happens. But that was her best shot. There's no question. You knew what to do, and putting a finger in there. And pretty much, when I talk about this, usually there's one person that has seen this. And almost in every single group I've talked to about that, there's some person who has themselves or witnessed putting the finger in the tracheostomy and just pulling forward and getting the patient to an operating room as quickly as possible. It's a heroic move. There's no question about it. It's an extreme move, but it's that or watch your patient exsanguinate. They may exsanguinate anyhow, but people do survive these. But they generally are going to survive these if you get to them nearly immediately and you have a short transport time to a hospital, or if they do it in a hospital, right? Or if they're there because they had their sentinel bleed. Sounds like maybe some time was lost when that oozing, you specifically say she was oozing, and then it opened up, right? 5 minutes can make the difference. 10 minutes can make a difference. If there's any bleeding, you got to transport that patient, okay?
Called a rapid response. Okay.
She was okay, so, okay, yeah. If it's, don't trust it if it stops. Convince your patient to go to the hospital. Okay, it's really high risk. So there you go. That's that. And yes, so compress, we talked about, and pretend that that's the vehicle you're in, right? Floor it, get them to the hospital, resuscitate along the way, give as much warning as you possibly can, and get that patient to us, and hopefully we'll be able to get that patient to the operating room. And when you start talking this about people, you definitely hear stories like that, because no one ever forgets when they've seen one of these things happen. It's a mess. Okay. All right. Any questions so far? Yes?
So in a situation like that, would it be beneficial to bypass locally or in favor of a regional trauma center?
That's a good question. One that you probably know better than I know. You need blood for that patient. You need resuscitative efforts. It's going to depend on your difference in time. Because if you get into a hospital and no one can get them to the OR, they're going to die, right? So I would say yes if the transport time isn't that different, because getting them to the hospital isn't what's going to save their life. Getting them to the operating room is what's going to save their life. Yeah.
A lot of places that work aren't available.
Yeah. So you know I know you guys know all the hospitals certainly better than I do. I work in one, right? So get them to the facility that you think can save them, because just being in a building ain't going to help them. You got to get to the operating room or IR, because IR can go and embolize these things fast and just shut it down. Yes, sir.
What Jeff was talking about, Dr. Siegel, if you have a patient that starts to ooze, given that you got to move them from wherever to the medic and so forth, should you try to start to overinflate the cup then and try to tamp it out before, or just leave it as is until worst case scenario, got it breaks loose and then you're...
Yeah, if you can see the source, if you can actually see the source of the bleed, you can identify it, I would, right, but if it's coming up from the tube, I absolutely would, yes.
If it's just news at that point.
Yep, and you know what? You might stop it at 20 cc's at that point, right? Because it's probably a relatively small opening, therefore lower pressure. You might be able to stop it right there. And if the patient's trach has to be changed when they get there, you say, sorry, just trying to save a life. I'm good with that, and I think that that's absolutely fine. But if someone is bleeding through the trach, yeah, you got to assume that it's going to open up. It's a ticking time bomb. You got to assume it's going to open up any moment, right? That story kind of gives me chills a little bit, because the ooze was there. And the potential was there. The patient made it to the operating room. The potential was there to have the patient's life saved. What?
Somewhere between 10 and 30 minutes.
Yeah, that's the difference. That's a huge difference. Yep. They start small, and like anything else, the pressure builds. There it goes. All right.
There's another question online. So if you have to pull the definitive airway, I think they're talking about
the trachea.
Would you attempt to open a new surgical airway lower than the stoma and make a new airway?
No, definitively not. You can't get to the tracheal rings. You can't. I mean, you could. No, and then your crike site's not going to be any good because you only have the neck cut. So sorry, that's not an option.
And then I had a question also. So you talked about one of the steps, multi-step process, where you actually pass the tracheal tube through the trach site.
Yeah.
And you use the balloon as a tamponade.
Right.
Would you also consider potentially going deeper, right, to try to somebody pass it?
No, because you don't die from hypoxia. You die from exsanguination. Right, this is different. You could pass it farther down and then put your finger in. That you could do. But protecting the lungs, the lungs aren't what killed the patient. It's the massive blood loss that kills the patient. But good question. All right. So bottom line, and first of all, this is not photoshopped. That's real. Just so you know. If it falls out, put it back in. Right? It's greater than 7 days old. Just put it back in. If it's less than 7 days old, get them to the hospital, okay? Don't muck with it. don't touch it unless your patient is really in extremis and you simply don't have a choice, all right? If the patient's in extremis and you can bag them, you can do anything to not have to touch that tracheostomy, do it, right? If the bagging isn't working, something is going wrong and you need to put a tube in there, put a small one in, have the most experienced person do it, you pretty much get one shot at it. All right. If it's occluded, take out the inner cannula. That's going to relieve 90% of the problems with the double cannula tracheostomies and suction. That's sort of basic stuff. It's basic care. If that doesn't work, take it out, right? It's been in there. The site's not going to close. You take it out, get into a hospital. We'll get a fiber optic scope. We'll put something new in, okay? All right. I think I can't underline this enough, right? If it bleeds, you have a ticking time bomb. Get your patient to a hospital, even if it's stopped. Don't let your patient talk you out of it. And compress. Compress with a balloon, compress with your finger, do whatever you can to try and compress that bleed while you're resuscitating, while you're on the radio, while you're driving, while you're monitoring the patient, right? All the things that you guys multitask and do phenomenally well, which is why we're so grateful to have you have all these skills and get them to a hospital that can provide definitive care. I think your question about where to go is a really good one, because getting them in a bed in the hospital isn't going to be what saves their life.
Always going to be able to get to that extreme point and put your finger down there. You're always going to be able to reach the place that's bleeding so that you can put pressure on.
You should be able to. Trachs are short, right? Trachs, this is the pediatric, well, here it is. You know, they're short, right? There's the trach, there's my finger. If you look at them side by side, if this is what caused the problem, I should be able to get in there. Now, could your finger be too big? Yeah, that's probably the more limiting fact than length. So whoever the piano player is with the delicate fingers, you take them and have them put in there, and then you have to really pull forward. Because remember, the artery's forward. Don't push backwards. You're not going to help. You might hurt. You need to pull the thing forward. Okay. Any other stories from the field about trach stuff? Trach's gone bad? No one? You guys have been pretty lucky?
I have a question.
Yeah.
So, is there any risk in doing CPAP?
No, it's a definitive airway. But you need a cuff. No, if no cuff, it won't work. Yeah, you have to have a cuff trach. So no, I mean same risks as through the face. Yeah, you have to have lower pressures. Your CPAPs, the ones that I've seen, do they tell you the airway pressure? I don't think you know the airway pressure. I mean, you're going to have to turn your pressures down, right? Because you're going through a smaller area. You're not going through the oral cavity, which is obviously much larger, and the trachea itself is larger. So you turn your pressures down, but you can do it certainly. Yeah. Okay. Remember, if you're bagging, you have 2 openings with a tracheostomy patient. You got to close off the other one. All right. Even though it seems counterintuitive to do that to your patient, you might have to do that to your patient. Yeah.
We don't carry trach collars, but the little pediatric non-breather mask will.
Yeah. And even if you don't have a pediatric one, just as long as it's blowing in here, if the patient's moving air, they're gonna suck air in. The pediatric ones work nicely. Yeah. And if you have to bag, remember get your neonatal bag, your neonatal mask rather, and put it right there. All right. That's enough for me talking, huh? That's a lot. We have trachs here. We have trach collars. You can look at the sizes. You can pull the inner cannula in and out. I think you guys should get up and stretch. I'm sure you're not used to sitting still for this long.
A couple of things really fast. For the sign-in sheet, if you haven't signed, please let me know. There's 2 forms over here. A big thanks to Nikki Austin for bringing in all the trach supplies. Thank you.
Thank you.
And Ashley Brooks for your unrelenting effort to get this thing live streamed. And you did.
Yeah, and thanks for taking your time to come out tonight. I really appreciate it. I just think you guys are awesome. You know, I work in a hospital, and I always thought, we get the patients all nicely packaged, and I mean, by the time they get to us, you have them on their backboards, and their IVs are in, and their oxygen's on, and we just love you guys. We love you guys. I have intubated in Wrigley Field, and man, that's how I realized how hard it is to intubate on your knees. I was in shorts, and I scraped the hell out of my legs, and I was on the ground. This guy arrested in the stands, and we were resuscitating him like amongst all the fans. It was really crazy. I've intubated in Wrigley Field and in Gillette Stadium where the Patriots play. Like, I kind of do this. I go to games and people arrest and I intubate them. That's just what happens. I haven't done it at Camden Yards yet, but I have started an IV in the stands for an unconscious patient. So I got close, but didn't actually intubate. So don't go to a sporting event with me. It's not very much fun. All right, thanks. You guys get stretched. There's stuff here.